Good morning. My name is okay. Good morning again. My name is Cristian Acosta David, and resident of second years the radiology and imaging, and this is my interesting case. Is a woman of 71 years old without personal history of significance. Began her condition 1 month ago, presented abdominal pain in the epigastrium with irradiation to the back in the Centro. In the night, weight loss. So, the Imagen study, we have an abdominal CT. Here we have two images of tomography in axial view in arterial phase, and we have an oval image with well-defined borders. It's observed with evident enhancement upon administration of control medium in the arterial phase with approximate measures 19 per 18 millimeters, suggestive of an aplastic process. In the venous phase, we have two images in axial view. In a venous phase, we will find the same lesions, but with less enhancement after the administration of material contrasted in the tail of the pancreas. In the same case, now we have three images of a tomography in axial section, arterial phase. We found in the second portion of the duodenum in a passerelle triangle, the passerelle triangle, the area is delimited by the junction of the 6 and common bile ducts, and the second and third portion of the duodenum, the neck and body of the pancreas, also known as triangular gastrinoma. Okay, because have this name, approximately 70 and 19% of the gastrinomas are found in this space. So here we have an oval image with partially defined borders. It is identified, which presents an enhancement to administration of control medium in the arterial phase with a hypodense center, which could suggest necrosis. Said lesion in close contact with the head of the pancreas without condition dilatation of the pancreas ducts. These findings suggestive of the neoplastic process. In the venous phase, now we have a stress imaging in axial view. We've found the same lesions, but with less enhancement after administration of control material. In these images, in coronal and sagittal view of venous phase, we have two previously described hypervascular images that show evident enhancement after contrast administration. So in the tail of pancreas and the second portion of the duodenum. So, which is the diagnosis? The differential diagnosis, I'm sorry. Interpancreatic splenum. The interpancreatic splenum is localized in the tail of pancreas. This is the second most common localization for the splenum. The Hansen is identical to spleen in all contrast phase. See, in our case, the enhance is less in the venous phase. So this is not a diagnosis. The pancreatic ductal carcinoma is a lesion hypovascular, infiltrated tumor associated with a pancreatic or biliary ductal obstruction and pancreatic atrophy. Findings not comparable with our case, so this is not the diagnosis. The pancreatic metastases, the lesions are hypervascular lesions, most commonly in renal cell carcinoma, investigable for NET, and we have no primary. So this is not a diagnosis. The pancreatic serous adenoma are classic microcysts or sponge appearance with lesion consisting of many small, enhancing septation and cysts. Finding is not comparable with our case, so this is not a diagnosis. And the pancreatic neuroendocrine tumors or NETs are lesions well circumscribed with non-infiltrated margins that usually, but not always, hypervascular and most conspicuous on arterial phase. Lesion usually hyperhanging to a lesser degree on venous phase, making a smaller lesion difficult to detect. Findings comparable with our case. So the pancreatic neuroendocrine tumors are tumors arising from pancreatic endocrine cells, islet of Langerhans. So the insulinoma, a B-cell tumor that causes hyperinsulinemia and then hypoglycemia, clearly not presented by the patient. The gastrinoma is a islet tumor that causes elevation of gastrin and acid gastric and posteriorly pectic ulcer that cause epigastric pain, clearly presented by our patient. And glucagonoma is an alpha cell tumor and elevation glucagon that cause classic skin rash and diabetes mellitus, clearly not presented by the patient. And non functionally derived from alpha and beta cells, no presentation by our patient. The clinical presentation divided into syndromics. Prostate clinical syndrome with abnormal laboratory findings or no syndromic tumors. The most common syndromic tumors include insulinoma, glucagoma, gastrinoma, and somastatinoma. Insulinoma is usually solitary and benign, and 90% presents with hypotriad, hypoglycemia, low fasting glucose, and relieved by intravenous glucose. And gastrinoma often multiple malignant, 60%, and associated with MEN1. So the Imagen findings CT are well circumscribed pancreatic mass with sharply defined non-infiltrated margins. Syndromic tumors is small in size, usually -3 centimeters, and the non-syndromic tumors usually much larger, more 5 centimeters, with frequencies and necrotic degeneration. Usually badly enhancing on arterial phase images and less conspicuous on venous phase, is similar with our case. Okay, lesion frequently calcified, unlike the carcinoma, may invade mesenteric vein with tumor thrombus. Don't usually obstruct biliary pancreatic ducts unless large. Hold our case. So the localization, 85% arise in pancreas, while 15% are ectopic. The most common ectopic localization is endodenum, for our case, stomach, lymph nodes, and ovary. 90% of gastrinoma arise in a gastrinoma triangle or a triangle passerelle. Gastrinoma triangle define cystic ducts and common bile duct, superiorly, second and third parts of the duodenum inferiorly, and pancreatic neck and burial medullary pancreas. Most commonly arise in duodenal wall. Okay, the question now is insulinoma or gastrinoma. So insulinoma most common is 50% of case, usually solitary and benign. 90% and 10% is malignant. In our case, is no solitary, see? Is multiple and malignant in 60%. That's the second most common and 55% of cases. This is the example for lesion hypervascular in the tail of pancreas. Then the diagnosis in this image is a insulinoma. So insulinoma is 50 and 60 decades, and the gastrinoma is in 40 and 50 decades. Overall may have slight female predominance and prognosis for better prognosis compared to pancreatic adenocarcinoma. Excellent prognosis for insulinomas, which are usually benign, but poor prognosis for gastrinomas. 5G survival with the liver metastasis of less 30% for glucagonomas. And the conclusion, we have hypertension lesions in the duodenum and the tail of pancreas, suggestive of a neoplastic process to consider a neuroendocrine tumor and probably gastrinoma. Thank you.
Thank you. So because of the clinical and radiological findings, up until this moment, the first diagnostic impression is a subarachnoid hemorrhage. The patient is further evaluated and in the Huntington case scale and is given a grade 3 because of the drowsiness, and with a Fisher grade 3 because of the dense subarachnoid hemorrhage with no intraventricular hyperdensities visible at the moment of the study. So we didn't have the clinicians didn't have a very reliable interrogation, so it's suspected to be because of the rupture of an aneurysm due to the lack of a traumatic event. So we have this patient's angio computer tomography, contrast enhanced, obviously, and then with patients that is suspected with rupture of aneurysm, we have to carefully evaluate all the vascular anatomy in the search of fusiform or saccular dilations from which the bleeding might come from, or any other vascular anomalies or malformations that might explain the subarachnoid hemorrhage and give us an etiology. After careful review of all the intracranial vessels in the patients that we can see through imaging, we didn't see any dilation, any non-saccular or any other form, and no other vascular malformations that might explain the hemorrhage. Here we can see the anterior cerebral artery with the anteriors communicating, which is like the first location that we might search. And we can also see the medium cerebral artery, the posterior one, the communicatings, posterior, and we don't see any saccular malformation and none other cause that might explain the symptoms or the hemorrhage of the patient. In any of the, obviously I just put in a representative images. I'm not putting the whole study, but upon evaluation, we didn't see anything else. So to continue with the evaluation of the patient, and contrast enhanced MRI was performed. I'm going to put first the sequence of diffusion weighted images with the corresponding ADC map. So in these diffusion weighted images with the ADC map, we can clearly see hyperintensity in the temporal lobe, in the right temporal lobe, with a focal area of restriction corresponding with hypointensities in the ADC map. And we can also see restriction in the posterior portion of the temporal recess of the lateral ventricles in both, which we didn't see anything in the non-contrast enhanced CT or the angio. Continuing with the diffusion weighted images, in the right hemisphere, we can see more areas of restriction and more areas of hyperintensities in the diffusion weighted images, and the point of hyperintensity that corresponds to the restriction. And superiorly, we can see another very clear area of restriction in the body of the right caudate nucleus, which it's very clearly visible. Something that we didn't see in the non-contrast enhanced or the angio CT. Continuing the evaluations in the flare sequences, we can see the same areas that were hyperintense in the diffusion weighted images are hyperintense in flare sequences, which correspond to edema. In the basal nuclei, we can also see a lot of areas of edema, and the region that was restricting in the body of the caudate nucleus, in the right caudate nucleus, is hyperintense in flare, with also edema in the external capsule. In these other flare weighted images or inversion recovery, we can see the more areas of edema in the right side predominantly, and in the T2 weighted images, we can see hyperintensity that corresponds with the hyperintensity in flare, and in the right temporal uncus, where we saw the restriction area and the areas of edema, we see that it's predominantly hyperintense in all the sequences that we have seen so far. Now I'm going to show a series of T1 weighted images with the contrast enhanced T1 weighted images on the right, in the non-contrast to the left, and on the contrast enhanced to the right. Okay. Very clearly, and the first thing that calls to our attention is that we have an abnormal enhancement of the leptomeninges in the basal cisterns and in the Sylvan fissure. When in the T1 weighted images, we don't see hyperintensity, and in the contrast enhanced, we see a very abnormal enhancement of these regions. No? We are here in the midbrain level, and all the cisterns and the fissures are enhancing with the leptomeninges. In another level, we can see the temporal oncus on the right side. Thus, the regions that we were seeing hyperintense in all the other sequences and the points of restriction, then in this region, we see that it's hypointense and with no clear enhancement of the region in the contrast enhanced T1 weighted images. And also, as a relevant finding at this level, we see the optic chiasm with clear enhancement posterior to the administration of contrast. We cannot, in another cut, we can also see that the area of the oncus in the temporal lobe, hypointense and with no clear enhancement. And we can also see the third cranial nerve in its cisternal portion with clear enhancement with the posterior to the contrast. The fifth cranial nerve is also enhancing in its external portion. And also we can see a dural enhancement of the dural meninges with an abnormal enhancement in the occipital bone. Sixth and 7 and 8 cranial nerves were also enhancing in their external portions. The area of restriction that we saw on the body of the right caudate nucleus is hypointense in T1 weighted images and with non-contrast, with non-enhancements posterior to contrast. And diffusely distributed throughout the brain parenchyma. Upon careful examination, we could also see or identify areas of nodular enhancement posterior to the administration of contrast. We can see in the left side a T1 weighted images with no contrast, and we see a hypointense dot that has enhancement in the contrast enhanced T1 weighted images in the superior left frontal gyrus, and also in the left thalamus. So because of all these findings, the leptomeningeal enhancement, the dural enhancement, the areas of nodular enhancement in the brain parenchyma, and the areas of edema in the brain parenchyma, and also the areas of ischemia, this patient is diagnosed with a neuroinfection with characteristic patterns of tuberculosis, which is the first possibility. With tuberculomas, with areas of subacute ischemia, secondary to vasculitis. And also we can see in the other images, and obviously better in the T2 weighted images, and hydrocephalus. If we go retrospectively with this patient, we can analyze the chest X-ray that they did, and we can see a clear loculated pleural effusion in the right side, and diffusely distributed micronodular pattern in both pulmonary sites, in both pulmonary cavities. And also with a non-contrast enhanced CT, we can see this miliar distribution of micronodules in both pulmonary cavities and the loculated pleural effusion. So in analysis, this patient with no clear background and not a reliable clinical history, or with in general with patients with no clear background and reliable clinical history, and with a non-enhanced, non-contrast enhanced computer tomography with hyperdense subarachnoid space, we have to think firstly of a subarachnoid hemorrhage, because it's the most dangerous one and the most common thing that we can see in the non-contrast enhanced CT. Nonetheless, we have to be aware that there are differential diagnoses of this finding in the computer tomography, which can be pseudo subarachnoid hemorrhage, which is characteristic of patients that have been recently or have passed recently with a, the RCP, severe meningitis, like our patient, venous sinus thrombosis, and previous intrathecal contrast that, well, in this case, it's very important, the clinical history of the patient that has been administered with intrathecal contrast. In this case, we have this patient with hypoxic ischemic brain injury due to the recent resuscitation. And we can see the hyperdense images in the basal sisters, but due to the hypoxic ischemic yes. Well, to review some things about the tuberculosis, meningitis is the most common manifestations of central nervous system tuberculosis. Hematogenous spread is the explanation, and the rupture of subpile and subependymal focus of the subarachnoid spaces, which gives the leptomeningitis. Enhancing exudate is the most common and relevant finding, like we had with our patient, but we have several findings we can have in the contrast enhanced MRI, like the ischemic infarcts we have with our patient due to the vasculitis. They can be detected in 41% of the patients with central nervous system tuberculosis, and mostly in the basal nuclei and on the internal capsule regions that result with vascular compression for the vasculitis that we were saying. Also, this patient, they mentioned that the areas of the temporal uncus were secondary to cerebritis. So we had also this thing with our patient, and it can be complicated with a cerebral abscess. Then that also can be confused with a mass or a tumor. In conclusion, central nervous system tuberculosis has various imaging appearances, and we have to be aware of the differential diagnosis of hyperdense subarachnoid spaces with patients with other, and review other imaging studies of the patient and their clinical history to be sure that our diagnoses are correct. Thank you. Nunca la compartí.
Good morning. We are going to continue with the interesting case. My name is Florencia Gonzalez. I am second-year radiology resident at Hospital Universitario, Dr. José Luterio González in Monterrey City. And I'm going to introduce my interesting case. Okay. Well, we have two images. The first one, we can see a transvaginal ultrasound of a female patient with a normal uterine bleeding. We have a sagittal gray scale transvaginal ultrasound image which shows uterus, and in the next image we have a transverse gray scale transvaginal ultrasound of the uterus also. We can see that the measure is 7.9 centimeters and 4.6 and 6.1 centimeters of normal measurements. We can see that there is an area of heterogeneous ecotexture at the fundus of the uterus. Okay, the next image is a sagittal also, and we can see more prominent heterogeneous ecotexture with areas of anechoic within the myometrium. Characterized by anechoic tubular image with a serpentinous appearance distributed in the myometrium of the body and uterine fundus, predominantly in the anterior wall. A parasagittal image. And in the next slides, we can see the endometrium, which is normal size according to the age of the patient. We can see the normal right ovary with normal measurements, a volume of 4 milliliters, excuse me, and the right ovary also with a follicle and normal size. Well, in this image, we have two images. The first one is a gray scale ultrasound and sagittal. We can see the anechoic tubular structures that we saw at the first, and then we use the color Doppler image, and we are able to see liasin and high vascularity in this area. The next image, we have a transverse approach, in which we can see also the anechoic tubular structures, and under the Doppler examination, we can see that it has a lot of aliasing and present color, and in relation with flow. Okay. Next, we can see a prominent vessel, which can explore under pulsed wave Doppler, and we can see that it has arterial flow with monophasic low resistance spectrum, like this one, and that also has a venous flow in another one image. We can see that the uterus is extremely vascularized with arterial and venous flow, and this data is suggestive of uterine arteriovenous malformation as a first diagnostic possibility. We can suggest at the patient a contrast-enhanced MRI of the pelvis for further evaluation. Well, the keywords for our case is female, reproductive age, a normal uterine bleeding, Doppler ultrasound, and contrast-enhanced MRI. The final diagnostic suspicion was in the first possibility uterine arteriovenous malformation. Well, we have a clinical history and presentation. We have a 24-year-old female patient with a history of 2 pregnancies. The first one ended on an abortion, and the second one was a C-section a year ago. She began 1 month earlier with abnormal uterine bleeding characterized by abundant flow and clots. When she was admitted to the emergency room, she had active vaginal bleeding and decreased hemoglobin level, requiring blood transfusion. Then the clinical the gynecologist required pelvic ultrasound, in which we didn't. First, we did a transabdominal approach, and then due to the difficulty of the diagnostics, we suggest to the patient a transvaginal approach. We explain the procedure, the benefits, the risk, and the patient accepted. The final diagnosis for this case was an uterine arteriovenous malformation. Well, there are differential diagnoses that we have to consider when we see augmented vascularity in the uterus. The first one is gestational trophoblastic disease. Typically, the patients with this entity has positive beta human chorionic gonadotrophin hormone overlapping and has overlapping image Doppler features that might coexist with an arterious venous malformation. In this image that we see here, we can see a sagittal color Doppler ultrasound of the pelvis in a patient with choriocarcinoma. Shows a normal increased myometrial vascularity, and the patient was treated with chemotherapy with complete resolution. If you see, there are many similar characteristics between gestational trophoblastic disease and an arterious venous malformation uterine. We have to differentiate these diagnostics by the laboratorial data, because the 2 entities tends to occur in female patients during their reproductive age. Another differential diagnosis that is more common in postmenopausal patients is the endometrial carcinoma, which is characterized by neovascularity that has low volume and high velocity flow. In this image, we have a transabdominal longitudinal ultrasound shows an heterogeneous endometrial mass with shadowing echogenic foci. The uterine cavity appears expanded with an obvious myometrial invasion. This was a case for endometrial carcinoma. It is also a differential diagnosis, but it tends to occur in patients with an age with an advanced age in comparison with the GTD. Another important differential diagnosis is retained products of conception that also has a positive beta human chorionic gonadotrophin hormone and can be negative, this hormone with cystic degeneration. We have a ultrasound image on Doppler examination, which reveal augmented vascularity in the uterus, and this was consistent with retained products of conception on the endometrial cavity with internal vascularity on color Doppler. It's an important also differential diagnosis. And another one is pelvic varicosities. In this case, we choose this coronal CT reconstruction contrasted during venous phase. We can see the venous ovarian, the left ovarian venous dilated of serpentinous aspect, and which consisted on pelvic varicosities. This can be seen also in ultrasound, like augmented vascularity during the Doppler ultrasound, and is a differential diagnostics. It is characterized by prominent parametrial vessels with normal venous spectral waves, varicosities, and the final differential diagnosis is uterine hemangiomas. I didn't find a representative image, but it is characterized by complex mass with acoustic shadowing due to phlebolytics. Besides, this one now shows arterial or venous spectral waves, like the uterine arteriovenous malformation. Okay, clinical presentation and general epidemiology. Well, there are exist two forms of presentation: congenital and acquired, which the congenital is a more rare presentation, and being the acquired the most common. We can see a history of post-traumatic or post-infection history in our patients, typically affect premenopausal women and during the 20 to 40 years, and rarely present in postmenopausal patients. The clinical presentation consists of menometrorrhagia, intermittent and unexpected, resistant to treatment. Torrential bleeding is suggestive of an arterial source. Up to 30% might require blood transfusion. It might be asymptomatic and not hemodynamically significant. Usually occurs in otherwise healthy individual. Another signs or symptoms are lower abdominal pain, anemia, dyspareunia, and habitual spontaneous abortions. The clinical profile in these patients is characterized by negative serum beta human chorionic gonadotrophin hormone, refractory menometrorrhagia requiring blood transfusion, and there is a fistulous connection between artery and vein without network of anormal vessels. Typical, this entity is typically easier to treat with transcatheter arterial embolization due to single feeding artery. Okay. Natural history and prognosis. Well, there is potential for life-threatening vaginal bleeding, mandating early diagnostic and treatment. In stable patients, expectant management has role, and spontaneous resolution sometimes seems common. In this patient, this patient was not this case. This patient was presented previously by Natalia and was treated by interventional radiology. The risk factors was prior dilatation, curettage, intrauterine devices, pelvic surgery, C-section or hysterectomy. Infection are the most common risk factors for this disease. We can see in this sagittal graphic shows an uterine arterial venous malformation at the level of the fundus of the uterus. Note the spongy appearance of the involved myometrium. Okay. Imaging features. Well, the first line imaging method is Doppler ultrasound, which is characterized by two mosaic patterns of color signals, apparent flow reversal and color aliasing, limited in delineating extent of the lesion. The apparent flow reversal is due to adjacent vessels of varying orientation and varying flow directions. And the color aliasing is due to high velocity flow. We have a sagittal transvaginal ultrasound with color Doppler in this patient, which is the same patient. We can see in grayscale that it has an heterogeneous echo texture characterized by some areas of hypoechogeneity. And during the examination with Doppler, we can see a color aliasing and flow reversal characterize this entity. During the examination with pulse wave Doppler, we can see high flow, low resistance arterial flow. Typically, high peak systolic velocity is above 100 centimeters per second. It is correlated with the necessity or the needed for treatment. I mean, it means the velocity is higher. It is more probably that the patient will need treatment surgically or by interventional radiology. Ultrasound, we can see in the grayscale ultrasound multiple tubular anechoic spaces within myometrium, majority distributed uniformly, producing a spongy myometrial echo texture. And this final image with the pulsed Doppler ultrasound, we can see an arterial spectrum of low resistance, resistance index of 0.40 and because systolic velocity of 33.5 centimeters per second. We have another one image, which is characterize this disease. Transvaginal ultrasound shows an ill-defined area of small anechoic spaces within the myometrium, producing a spongy myometrial echo texture. And then sagittal transvaginal ultrasound with color Doppler in the same patient shows marked vascular flow within the myometrium, corresponding to the spongy myometrium in the grayscale, classic features of uterine arteriovenous malformation. Then we have a coronal T2 weight image, MRI, in the same patient. Shows obscuration of the uterine zonal anatomy with heterogeneity of the anterior myometrium, including flow-related signal voids that are consistent with the uterine arteriovenous malformation. Then we have another MRI image, and this is a sagittal reconstruction. T2 weighted image in the same patient again shows a poorly defined mass with scattering flow voids within the anterior myometrium. And then we have a coronal T1 weighted image with contrast in the same patient, and FATSAT shows an irregular enhancement and flow voids within a poorly marginated mass, consistent with transmural arterial venous malformation. Then we have a frontal angiogram on the same patients of a right internal iliac artery. With excuse me, I was distracted. What? Frontal angiogram of a right internal iliac artery injection in the same patient shows a prominent right uterine artery. We can see here. And then an opacification of a tangle of vessels consistent with arteriovenous malformation. Another ultrasound image, we can see the same features. And then we'll have the treatment or therapeutic options. Well, the first therapeutic options that allows preservation of fertility is transcatheter arterial embolization. Must be treated uterine arteries bilaterally due to cross-filling, and might use healthfoam, polyvinylic alcohol particles, or glue. Rare complications include perianal skin sloughing, uterovaginal or rectovaginal fistulas, and lower extremity neurologic deficits. The definite treatment, if fertility no longer desired, is the hysterectomy. And if asymptomatic, the patient could be observed for spontaneous resolution. In those patients stable, the resolution might respond to the course of medical therapy. We have to consider uterine arteriovenous malformations in patients with vascular uterine mass and unexpected bleeding in the setting of recent pregnancy, dilatation and curettage, or other intervention. We have the reference here, and we thank you. Yes.
Good morning. My name is Estefania Brosi, and I am a second-year radiology resident from Hospital Universitario Dr. José Luterio González. This is my interesting case. I hope you enjoy it. Starting with the patient data, we have a 5-day-old male born at 36.2 weeks of gestation via spontaneous vaginal delivery, who was admitted to the neonatal intensive care unit due to follow-up of the preterm newborn patient. During his stay, the infant presented an episode of bloody stools, and the clinical examination reports abdominal distension. As a comment, the infant was born after an uncomplicated pregnancy. The only medication that mom used in the pregnancy was fosfomycin for 2 urinary tract infections during the second trimester of the pregnancy. On the screen, we have 2 abdominal plane radiographies obtained with a vertical beam and an horizontal beam. Both of them shows dilatation of the intestinal loops with intramural gas right here and pleural venous gas, showed as lineal branching radial lucent vessels that extends from the region of the main portal vein toward the periphery of both hepatic lobes. With these images, the question arises as to whether if there was any complication as fluid or intestinal perforation. So we decided to practice an ultrasound. On the abdominal ultrasound, we show free fluid in the right and left paracardic groups, the right iliac fossa, and interloop. We should consider that in newborn patients, we may have a mild free fluid, but we need to complement with other findings. On this rate scale abdominal ultrasound images, portal venous gas is seen as some mechanic pulsing moving with the blood flow. The gas is an extension of the intramural gas that enters the veins to the bowel wall and passes into the portal venous system. We have 2 grayscale images and 1 color Doppler image ultrasound in the topography of the upper and the lower left quadrants, in which the intestinal walls are observed with loss of their differentiation characterized by an increase of their echogenicity associated with echogenic nodal images that project a dirty shadow. These findings are compatible with pneumatosis. On the color Doppler ultrasound, this one shows an increased flow in the intestinal wall in relation to hyperemia. And the final diagnosis was necrotizing enterocolitis. What happened next? Well, conservative management with orogastric tube, meropenem, and paracetamol was decided. However, baby persists with an abdominal perimeter of 31 centimeters with diminished bowel sounds and respiratory distress, which was managed with intubation, posterior extubation, and continuous positive airway pressure therapy. Enteral stimulation alternated with parenteral nutrition was started. And a week later, the current physical examination was with the baby was with absence of abdominal distension. We have two more abdominal radiographies obtained with a vertical and an horizontal beam that shows an absence of the dilatation of the intestinal loops, the intramural, and the portal venous gas seen in previous imaging studies. So the patient presents a clinical and radiological improvement. Our differential diagnosis includes the newborn bowel obstruction, the newborn spontaneous intestinal perforation, the enterocolitis of term infants, and non-specific gaseous distension of the bowel. Necrotizing enterocolitis is considered a multifactorial neonatal disease characterized by intestinal inflammation and mucosal injury, and leading to necrosis and perforation of the entire wall. This is a significant cause of morbidity and mortality in preterm patients. And at our hospital for 2018, this pathology was positioned as the cause of 25% of late neonatal deaths. Necrotizing enterocolitis most commonly manifest within the first or second weeks of life. The symptoms referred to the gastrointestinal tract include feeding intolerance, vomiting, diarrhea, and blood in the stool. However, there may also be non-specific generalized symptoms, including lethargy, temperature, and blood pressure instability, and apnea. Physical signs include abdominal distension, and in more advanced cases, palpable distended bowel loops and abdominal wall erythema and edema. The neonates with severe disease may ever present in shock. Talking about the imaging modalities, we have the plain abdominal radiograph and the sonography. The first one is the current modality of choice for the evaluation of the neonate suspect with necrotizing enterocolitis. The main observations to be made on the plain abdominal radiograph includes the presence, amount, and distribution of gas, including the intramural gas, intraluminal gas, and portal venous gas. The time of follow-up depends from the severity of the necrotizing enterocolitis, and it may vary from 6 to 24 hours. The ultrasound has some advantages. It provides in real time direct images of abdominal structures, particularly the bowel, and of fluid in the peritoneal cavity. These are some specific findings on ultrasound. For example, the bowel wall thickness is markedly thin or up to 3 millimeters on a necrotic bowel. The echogenicity, as we saw in the case, has a loss of its normal gut signature. The peristalsis can be sluggish or absent. We may have free intraperitoneal fluid, intramural gas, portal venous gas, as we see in the case, and pneumoperitoneum. We didn't see it. According to Bellelat, the disease can be staged into 3 groups based upon historical, clinical, and radiographic data. In general, the stage 1 that includes a suspect and the stage 2, a definite necrotizing enterocolitis, are managed medically, whereas the stage 3, the advanced, is managed surgically. These are my references, and thank you for your attention.